slides as well.
That would be great.
There it is. Okay, good. Okay, so let me see how to click. Oh, do I just tell you to move it forward, Caitlin?
Yep, just let me know.
Okay, I'm ready. Okay, so I think one of the most important things to know about osteoporosis is the definition. It's not what is the T-score or anything. It really just means your bones are fragile and prone to breaking. And if you think of that as what osteoporosis is, it'll be easier to remember who has it. So next slide, please. So here's a picture on the left of normal bone. We can see how nice and thick and opaque almost it looks, even though it has holes, it's hard to see through. And then on the right, the bones really just get fragile looking. Like these walls of these holes look relatively thick, but it can be horribly thinner than this. And so the bones are just not strong anymore. Next slide. So there are several different ways to diagnose osteoporosis. So of course we all know about DEXA scans, and that if the T-score in any spot, so you know how they give T-scores at the femoral neck and at the lumbar spine and at the Ward's triangle and at blah, 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 whatever is the lowest T-score defines what their T-score is. So it's not an average, it's not what's the best one. You take the worst T-score, and if it is minus 2.5 or lower than that, they have osteoporosis by DEXA scan definition. Next slide. Another way to diagnose osteoporosis has nothing whatsoever to do with a DEXA scan. If that person has walked down the street and fallen over and they broke their hip, that is indicative of fragile bones, which is the definition of osteoporosis. So you do not need to send a person who just had a hip fracture from tripping on a curb to get a DEXA scan to prove that they have osteoporosis. They have proven that they have osteoporosis by breaking something with such a minimal thing. And so their bones are fragile and need help. So sometimes you'll get somebody who has fallen in some way and you're not quite sure if it counts as a fragility fracture, meaning they broke their bone because their bones are thin, or did they break their bone because the fall itself was horrible. So if it's a high impact thing, they got hit by a car or were in a motor vehicle accident, or they fell out of a tree, those are more obvious. But if I can't quite tell, was it the fall that was bad or the bones are bad, I'll ask the patient, you know, if you were 20 years old and this exact same thing had happened to you, do you think you would have broken a bone? And they usually can say, no, I used to trip and fall, I've been clumsy all my life, I've never broken anything till now. Then it's more likely that the bones themselves are the problem than that the fall or the injury was the fault. Next slide. So we have the T-score of minus 2.5 as one way. We have just a fragility fracture, an injury that caused a broken bone that really wouldn't have happened if the bones weren't fragile. And then we have another way to diagnose osteoporosis, which is called a FRAX score. Every time you get a DEXA scan, you're going to see that the T-scores indicate normal bone density, osteoporosis bone density, or that in-between gray zone, which is called osteopenia. It is only when the T-scores say osteopenia that you need to look at the FRAX score. You may get a FRAX score with normal bone density T-scores reported at the bottom of the page, or with osteoporosis T-scores reported at the bottom of the page, but you don't care about the FRAX score except when the patient's T-scores indicate osteopenia gray zone. The FRAX score looks at can you go to the next slide? I think I have more details. Yeah, it's reported at the bottom, and it's for those people who have osteopenia alone. Next slide. So basically, your use for the FRAX score is to say, is this person who has osteopenia considered low risk osteopenia, low risk for fracture, versus high risk osteopenia? And next slide. So basically, those people who, in their FRAX score, it'll show you two different percentage numbers. If the percentage for major osteoporotic fracture is 20% or worse, they fall into the high-risk osteopenia range. Or if their hip fracture risk is 3% or greater, they fall into the high-risk osteopenia range. And these people should be treated with medication just like somebody whose T-score was horribly low and obviously in the osteoporosis category, because these people are just as likely to fracture as those who have a T-score of -3, for example. High-risk FRAX scores, 20% or 3%. You use this in those whose T-scores say osteopenia, but you need to know, are they low risk or high risk osteopenia? If they fall into the low risk FRAX score of less than 20% or less than 3%, you treat them like we historically treat people with osteopenia. You tell them, make sure you get adequate dietary calcium. If you're not getting adequate dietary calcium, that's when you say take oral calcium supplements. Make sure their vitamin D levels are above 30. If not, you tell them to take supplements, eat foods with vitamin D. It's hard to get those. You tell them to engage in regular, gentle weight-bearing exercises and things that enhance balance and reduce fall risks, like if they have rugs and ottomans all over their house. That's how you treat osteopenia. Osteoporosis, high-risk FRAX scores, they already broke their hip, or they have T-scores that are horrible. You want to treat them with osteoporosis medication. Next slide, please. Also, if they have osteopenia T-scores and they break, remember, if they break a hip or vertebra, it doesn't matter what their T-score is, osteopenia, normal osteoporosis, that's a fragility fracture, they have osteoporosis. But if they never broke anything so far, their T-scores are in that gray zone of osteopenia, and they break their proximal humerus or pelvis or their distal forearm near their wrist with just a gentle fall, that also counts as osteoporosis, okay? So, well, osteopenia worthy of treatment as if they have osteoporosis, which they do because they've proven they have fragile bones. Next slide. So the three ways, just as a summary: a DEXA scan showing a T-score of -2.5 or lower, a fragility fracture of the hip or spine regardless of what the T-scores are, or if they have osteopenia on T-scores and their FRAX score is high, or they broke their wrist or their upper arm or their pelvis. Fingers and toes don't count. Everybody stubs their toe and breaks it. We've all got gnarly looking little toes. But the lower extremities, it's except for the hip, obviously, but like if you break your tibia, the jury's kind of out as to whether or not those things count as fragility fractures. The tibia is super thick. It's hard to break it, but you know, it would raise questions and prompt further investigation. So we know about pelvis, distal radius, and proximal humerus. Okay? Next slide, please. So this just says bone loss, you've come to the right place. Looks sort of silly. Next slide. So the risks of developing osteoporosis, things that we probably already know, like age, the older you get, and especially after menopause, the more thin your bones are. Female bones are thinner than male bones, so women are more prone. If there's osteoporosis in your family, if you've had fragility fractures already, obviously you're at high risk for further fracturing. Poor nutrition, if you don't exercise. If you've needed steroids extendedly, so 5 milligrams of prednisone for 3 months in a year or more, is considered the amount of steroids that's considered long-term steroids. If you have rheumatoid arthritis, treated or untreated, but official rheumatoid arthritis, there's something that inflammation does to the bones near the joints that somehow or other predisposes people to osteoporosis. We don't really know too much about why that happens. If men have low testosterone chronically, think of it as women after menopause. Low estrogen in those women predisposes their bones to thinning. Low testosterone in men, same idea. Excess alcohol. So this is 3 drinks a day of alcohol or more is a risk factor. Smoking. If you just don't weigh very much, your bones don't have much weight to hold up. So less than 127 pounds is considered a risk factor. And really, I tell my patients all the time, this is one of the few times when I tell you don't lose weight. Most of my people I'm telling all the time, please try to lose weight. But this is one of the few situations where it wouldn't be advised. If they don't have enough vitamin D or calcium, and if they tend to fall. Now, at the bottom, secondary causes, and this is where we start talking a little bit about diabetes. So type 1 diabetes is considered one of the secondary causes of osteoporosis. Other secondary causes could be chronic untreated hypothyroidism, things like that. But type 1 diabetes is absolutely a risk for developing osteoporosis. Next slide. So type 1, part of the reason is for some reason because of inability to use some of our metabolites properly with insulin issues. We have poor bone quality developing over the lifetime. They definitely have an increased risk of fractures, fragility fractures. At the age when most women are achieving peak bone mass, which is late 20s, early 30s, they often don't quite get there. And a lot of it does have to do with a metabolic inability to use some of the nutrients and glucose because of insulin inefficiency early on in their lives. And also, remember, type 1 is autoimmune, and celiac disease is also autoimmune and much more common than we think. So if they're not absorbing their calcium, their vitamin D properly, then that's another sort of indirect reason why their bones may not have developed as sturdily as a non-type 1 diabetic. And then any diabetes, type 1 or type 2, or if it's due to a pancreatectomy, they do tend to have poor bone quality, which isn't something that we can see on the DEXA scan. Remember, DEXA is looking at the density of the bones. It's looking at how much they can actually measure. But you could say that there's a lot of bone, but it's super squishy. So the DEXA doesn't necessarily pick up the quality of bone, it measures quantity. So when they do special types of assessment of bones, they find that people with diabetes tend to have poor bone quality. And there is a worse risk of osteoporosis if any diabetic has very poor control of their sugars, and it's also an increased risk if they are on insulin. Next slide. So type 2 diabetes, in the old days we used to tell people who had type 2 and who were sort of typically more overweight and obese that you have very low risk for osteoporosis or breaking a bone because you've been putting the extra weight on the bones. They've had to stand up and withstand that pressure, and they've been able to stay strong. And there's more padding on us. If you happen to fall, you may have more cushion built in. But in fact, we know that with type 2, this is now considered an independent risk factor for developing osteoporotic fractures. So they, in fact, are seeing that, yeah, maybe even their DEXA doesn't look that bad, but they're fracturing like someone with a much worse T-score than what they're measuring at. So they think that even getting through some of the thickness of the skin is making DEXA scan reports overestimate their T-scores, meaning read higher and better than what they actually are. So, if you've had diabetes for longer, like I was saying, longer duration of diabetes and on insulin, And they know that diabetes with type 2 tend to have denser bones, partly from that resisting all the weight, but in fact the quality of the bones isn't so good. Also with diabetes, we think, okay, well maybe it's neuropathy. They don't sense on their feet very well, so they're falling. So the more you fall, the more chance you have of breaking something. But even if they control for falls, there is still an increased rate of osteoporotic fracture in type 2 diabetics. Pioglitazone and other TZDs, we know, can cause some bone loss over time. So when they look and control for that, there's still a higher risk. Although you have to at least tell your patients that pioglitazone over very many years could potentially make your bones a little thin, but it's still higher risk just by having diabetes. Next slide. Okay, so like I was saying, the T-scores may look okay in a type 2 diabetic, but the fracture risk in fact is higher than what those T-scores look at, and it's the bone quality seems to be poorer. They have some reduction in their ability to form new and healthy bone, and then there are other things we just can't understand yet, but they're investigating. Next slide. So I was just mentioning this, if they have peripheral neuropathy, or they tend not to be very fit or exercise, not very well coordinated, or they have retinopathy and can't see, they may be more prone to falling. With hypoglycemia, of course, you worry about dizziness, wobbliness, maybe even passing out. So anything that makes you more prone to falling, of course, does raise your risk of breaking something. And even more so if the bone quality itself isn't great. Next slide. Okay, this may be the last slide. So how do we treat osteoporosis in people with diabetes? It's essentially the same as for anybody. So you want to encourage weight-bearing exercise. And I tell people, you do not need to go to the gym and lift weights. If you're putting a gallon of milk into the fridge, lift it over your head a couple times in each arm and then put it into the fridge. Little things like that. Work on balance. If you're talking on the phone, like hold the phone here and lift up your left leg 3 inches and just talk for 5 minutes with one foot off the floor. It helps you develop balance, and then switch to the other side and keep that foot off the floor. Little things like that can actually help people's sense of balance. And of course, take ottomans and rugs out of the, little rugs off the floor out of the way so you don't fall. Make sure they're getting adequate calcium and vitamin D, and then controllable risk factors such as smoking, excess alcohol, things like that, counsel them about. And then as far as medications, because everyone with osteoporosis, there's a lot of press out there lately with fewer and fewer people taking osteoporosis medicines, and it doesn't make sense. They read about atypical femoral fractures. So the data says you are more likely to be struck by lightning than to develop an atypical femoral fracture or osteonecrosis of the jaw from bisphosphonates. So you can, and that's in the, I think it's the Osteoporosis Foundation data or the ACE, American Association of Clinical Endocrinologists data. They have really good graphs saying more likely to have this happen than an osteoporosis problem, and more blah, 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 blah. Meanwhile, the fracture risk in someone with osteoporosis who does not take medicine to help lower that risk is way up here. And the mortality goes up by 20% annually after an osteoporotic hip fracture. So it is not a minor thing to have osteoporosis and just let it slide because you're worried about this extremely low risk of atypical femoral fracture. So explaining some of those numbers to people and showing them some of these pictures about lightning strikes tends to help get them more comfortable with the idea. So oral bisphosphonates are cheap. They've been around forever, and most people do tolerate them. Once every Saturday, take that. If they don't like that kind of thing, IV once a year is super easy to do for most people. It's generic now, so it used to be about $1,300. Now I believe it's much, much less expensive. If you can just tell the insurance that they tried the oral one, they had horrible reflux, can't do orals, they'll usually cover the once a year reclassed. when you're going to prescribe Reclast, this once a year infusion in zoledronic acid, tell your patients beforehand to expect 3 or 4 days of mild flu-like symptoms, like mild fever, feeling headachy and achy all over. Tell them to expect it so they don't think they're dying from this thing they just got. Tell them to take some Advil, some Tylenol. They'll get through it. And if they're prepared for it, they know you know what you're doing, they don't freak out, and then they'll go back next year when those same symptoms will occur, but about 25% of the degree, so 75% less severe than the year before. Third year, probably no symptoms. So just prepare them for that. Make sure they're hydrated. Always remember you want their vitamin D to be good before you start these medicines, because bisphosphonates, whether they're by mouth or vein, can transiently lower your calcium, and you can get symptoms of hypocalcemia like muscle cramping, bone pains, aches. It goes away, but you're less likely to have those symptoms if your vitamin D is well up into the normal range, like well up into the 30s and 40s before you give these medicines. It helps the patients feel better as they're getting their treatment. Denosumab is every 6 months. It's a shot in the arm, just like a flu shot size needle, even a little smaller than that. And it's a very effective, safe medicine. And this is the one you can use with the worst kidney function. So if you have somebody with a GFR that's 30, horrible bones, you can use denosumab in this population. Teriparatide and abaloparatide are the ones that you give as injections at yourself at home with a pen, and they make your bones build up. You only use them for a period of time, 18 months or 24 months, depending on which one, but they're very efficient and effective at building up bones. They're very expensive. Insurance does not like to pay for them until you've kind of failed the other options, but they are really, really good medicines. The people you cannot use them in are any people who have had radiation to any part of their body at any time in their life, because the potential black box warnings, it's not happened in people ever, you can tell people that, but in some rats, because it builds up bone, if you ever had radiation, it touched a bone somewhere, and any medicine that's going to make you build up bone could make that bone build up abnormally in an area that was previously radiated, and could develop a tumor or osteosarcoma. So those are the black box warnings for the teriparatide and abaloparatide. But again, you can tell your patients, humans have never gotten this from these medicines, but because some rats did, we just don't use it in people who had radiation. We also limit it to the 18 to 24 months of your whole life so that you don't get too much of it over your lifetime. So those are the treatments. There are others like raloxifene, or one of the bisphosphonates is called ibandronate. It was Boniva. Those are my least favorites, both raloxifene and Boniva or ibandronate, because they only help the spine. If you have somebody with osteoporosis, the most significant risk really in terms of osteoporotic fracture is hip fracture. So you don't want to give them an osteoporosis medicine that's not going to help their hips. So I don't use Boniva or ibandronate, and I don't really use raloxifene, only because I need their hips to be protected, not just their spine. So it's not that they're bad, it's just they don't do all the stuff that these other medications can offer. Next slide, I think, is the last one. So any questions about that?
So this is Jennifer Boyd again. I have several questions. I don't want to hog the questions, so maybe I'll ask one or two and see if anybody has any others before I ask them all. I'm assuming from what you said that inhaled corticosteroids don't really present any risk for somebody with osteoporosis or osteopenia. There's not enough absorption compared to oral?
Well, so we don't know. I would say if you have somebody who, especially menopausal age, if they're on chronic inhaled steroids, I would probably be extra careful to check at least their DEXA, maybe starting sooner than you might. You might not wait till age 65, for example. because we all know that we're told joint injections with steroids or inhaled steroids don't affect us systemically, and yet how many of us have seen people's blood sugars go up when they get steroids, right? So there's absolutely some systemic effect.
Okay.
And you have to at least consider that it could be affecting their bones.
And what about long-acting contraceptives? I know that I've heard that Depo-Provera can put younger women at risk for osteoporosis later in life. Is that true of other progestin-containing long-acting contraceptives?
So the progestins, yes. So it's because those are similar to steroids somewhat in their effect. Progesterone, corticosterone, any of those words that end in something like that can potentially have, in a roundabout way, almost like a steroid effect on the bones. So it is something to consider.
And so you just make sure they're dosing well with, or getting enough calcium and vitamin D in their young age.
Another way they can do that is because they feed back and suppress estrogen. And estrogen, if you're 30 and really your estrogen's low because you're just taking progestins to suppress ovulation, you're going a long time potentially with low estrogen levels, not the birth control pill, but lower than that.
Yeah.
Another risk factor.
I have a couple more questions, but if anybody else does, I don't want to take up all the time. No. I have two patients who are male type 1 diabetics. One was an adult onset type 1, and the other one he got his at age 20. They're now in their 50s, maybe 60s. Should I be getting DEXA scans on those guys?
I would.
Okay.
Yeah, I would.
And I think this is my last question. So every so often I hear that dairy products actually are not good for building bone. Oral dairy products, for even though they have calcium, that somehow the dairy, and I've looked into this recently, on PubMed and stuff like that, and I couldn't find anything to confirm that, but it's sort of a common statement amongst certain groups of people, Is there any validity to that?
Not that I haven't found either. I haven't found that. I mean, any dairy things you get are going to be some source of calcium. If you can absorb it properly, you're going to be helping your bones out. But if you just drank milk and ate cheese all the time, you can still develop osteoporosis, because just getting adequate calcium is not a foolproof way to avoid osteoporosis. There's so many factors. So it's encouraged to get dairy products so you get calcium, but it's not going to hurt anything to get calcium in your dairy products. And just also tell people, if they say, well, I drink vitamin D fortified milk. There's no regulation about how much vitamin D is actually in any gallon of milk. It just is fortified with it. So don't let them fool you into thinking that they may not also need some supplemental vitamin D. So.
Okay, thank you. That was very helpful. That was great.
All right, well, thank you, everybody.
Yeah, thank you both so much, Jennifer for the case and Jessica for the excellent didactic. I will send out a reminder with the next session and everything, but thank you everybody for a great session today.
Thank you.
Thank you very much. That was very helpful.